Hi everyone, my name is Caroline Pete, and today I will be talking about the importance of lung capacities in a pulmonary function test. Lung capacity is the volume of air in the lungs upon the maximum effort of inspiration. The average lung capacity in a healthy adult is around 6 liters. The total lung capacity increases from birth to adolescence and plateaus around 25 years old. Determining lung capacity can be important to the evaluation of various suspected lung diseases and other abnormalities. Some factors associated with the ranges of lung capacity among individuals include age, gender, body composition, and ethnicity. For example, men tend to have a greater lung capacity than women. So to put it in perspective, you can see this image right here. Females have around 4 liters on average, and males will have around 6 liters. This can be associated with the fact that on average, men are usually bigger than women. Another good example in relation to body composition is that tall individuals have a greater lung capacity than short individuals. Lastly, an example of ethnicity and its effects on lung capacity can be seen in the comparison of people of African and European descents. It has been found that individuals of African descent have lower total lung capacity than individuals of European descent. Additionally, less common factors that can affect lung capacity include the level of physical activity, chest wall deformities, and respiratory diseases. Total lung capacity can be calculated by measuring the 3 lung capacities: inspiratory capacity, functional residual capacity, and vital capacity. Inspiratory capacity is the maximum amount of air that can be inhaled after reaching the end of a normal exhale. Functional residual capacity is the amount of air that stays in the lungs after a normal exhale. And vital capacity is the maximum amount of air that can be exhaled after a deep inhale. So as you can see in this image right here, these capacities can be further divided into 4 volumes. So you'll have tidal, inspiratory reserve volume, expiratory reserve volume, and then residual volume. The tidal volume is the amount of air that goes in or out of the lungs with each full breath in and out. You can see in this figure right here, so you'll have right here in between, so here's a breath in and out. You can see the resting inspiration and resting expiration. So you'll have your tidal volume in between that. On average, this volume should measure to be around 500 milliliters in males and 400 milliliters in females. The inspiratory reserve volume refers to the extra volume of air that can be inhaled with maximal effort after completing a normal inhale. So you can see again in this figure, here we have again the resting inspiration, resting expiration, and then your expiratory reserve volume. So that wave right there. The expiratory reserve volume is basically the opposite of inspiratory, as it is the extra volume of air that can be exhaled with maximum effort beyond completing a normal exhale. So you've got your normal exhale line right here, which then that would go beyond. Lastly, the residual volume is the volume of air that stays in the lungs after a maximum forceful exhale. So this figure displays the volume after maximum expiration threshold as the volume of air that was unable to be expelled from the lungs. So here is your maximum expiration or exhale threshold, and then this volume would be going beyond that threshold. This causes the alveoli to stay open all the time. Measuring the lung capacity at these different phases of the respiratory cycle allows the total lung capacity to be calculated. This can be calculated using the equation total lung capacity equals functional residual capacity plus inspiratory capacity. So in other words, the volume of air in the lungs after the maximum effort of inspiration is equal to the amount of air in the lungs after a regular exhale, in addition to the maximum amount of air that can be inhaled after completing a regular exhale. Each of these capacities and volumes can be measured by a pulmonary function test. Pulmonary function tests show how well the lungs are performing based on the volume and capacity measurements it provides. These tests serve as a non-invasive way for a healthcare provider to diagnose and determine treatment of various lung disorders. There are two methods of pulmonary function tests that are oftentimes used together to collect information on lung performance. These two methods can be identified as spirometry and plethysmography. Spirometry is actually a method that I'm very familiar with. This test is done using a spirometer, which is a device that has a mouthpiece attached to a small electronic machine, as you can see in this image right here. So here's your mouthpiece, and then it connects to this electronic machine. The patient blows into this mouthpiece, and then the data is provided on the screen. So mouthpiece, and then here's your data. So it has the lung volume, inhalation, exhalation, time. The device is able to digitally convert the airflow rates into electronic signals, which we took a look at when we were learning about the calculation of lung capacity. These signals will be analyzed, usually resulting in a lung or pulmonary disease diagnosis. Incentive spirometers are another form of spirometry used for more of a post-diagnosis. So I actually have an incentive spirometer that I use at home, and I thought I would show you guys a little demonstration. So this is what an incentive spirometer looks like. It's obviously a little less complex than an electronic spirometer. So these are usually used for patients that are diagnosed with a lung or a pulmonary condition. And so what this will do is basically it serves as a way for you to exercise your lungs. So it will strengthen and expand your lungs the more that you use it. So here's the mouthpiece that it kind of works a little bit opposite. So in this case, you'll exhale all your air and then use the mouthpiece and inhale. And when you're inhaling, there's this little gauge right here. And so you can move this. Each patient has a different recommendation. My doctor has me at a goal of around 3,000 milliliters. So for everyone, it's different. Some people, I started off at 500. It just kind of depends. And so usually patients will do this every day and just try to reach their goal. And that way it works on strengthening and expanding your lungs. So I'll show you a little demonstration. I'm going to exhale all my air out and then breathe in and try my best I can to get this ball up to 3,000, which is my goal. So didn't quite make it to my goal, but that is kind of, the more you work on it, the closer that you'll get to your goal. So again, this exercise should ultimately help the patient increase their numbers over time, improving their pulmonary function. Plethysmography is another slightly more complex method of pulmonary function testing that helps a physician identify the amount of air in a patient's lungs after they complete a deep inhale. It also allows them to determine how much air stays in the lungs after they complete a deep exhale. In other terms, this test measures total lung capacity, functional residual capacity, and residual capacity. To complete this test, the patient will enter an airtight enclosed clear plastic box, which you can see demonstrated in this photo. Then they will place a clip on their nose and breathe normally into a mouthpiece like this one right here. After completing a normal expiration, they will be asked to pant into the mouthpiece, which will alter the mouth and box pressure. When a patient blows into the mouthpiece, the pneumonotachograph, labeled right here, measures the flow and volume. And then the PM transducer right here senses pressure at the mouth, and then the PBX transducer senses pressure in the box. So these transducers are connected to amplifiers, as you can see right here, that display the box pressure or lung volume and mouth pressure on a monitoring system. This test helps detect ventilatory impairments such as restriction and obstruction. There are two types of disorders that can cause problems with air moving in and out of the lungs, known as obstructive and restrictive diseases. Obstructive lung diseases cause a disproportionate reduction of maximal airflow from the lung in relation to maximal volume that can be displaced from the lung. So common causes of obstructive diseases include asthma, bronchitis, bronchiectasis, and chronic obstructive pulmonary disease. Asthma, which is often triggered by allergens, infections, exercise, cold air, or irritants, has inflammation or smooth muscle contractions that cause the respiratory tubes to narrow. Bronchitis causes the respiratory tubes to become inflamed due to infections or airborne irritants like cigarette smoke. So you can see in this image right here, this is what chronic bronchitis looks like. So you'll have a healthy respiratory tube, and then a respiratory tube with chronic bronchitis. Bronchiectasis causes the respiratory tubes to widen and prevents the ability to clear secreted mucus. This is usually due to infections such as pneumonia and inherited dysfunctions like cystic fibrosis. Lastly, chronic obstructive pulmonary disease, also known as COPD, is the chronic inflammation of the respiratory tubes and/or lung tissues, which is usually caused by chronic bronchitis or emphysema. Restrictive lung diseases decrease the amount of air that the lungs are able to hold. This usually occurs because of a decrease in elasticity of the lungs or due to impaired expansion of the chest wall during inhalation. There are two types of causes that can be responsible for this disease, known as intrinsic and extrinsic. Intrinsic causes are due to the destruction of the lung tissues. This can happen when there is an infection present, such as tuberculosis, or an autoimmune disorder, such as sarcoidosis. Drugs, radiation, and cancers can also be associated with this. Extrinsic causes are due to issues with the tissue layers that line the lungs. These issues can arise from inflammation or damage to the lungs. Extrapulmonary problems are another example of extrinsic causes. This can occur from neurological or neuromuscular disorders that affect the breathing muscles. Chest wall deformities can also contribute to this. So to put it in perspective, here's an image of a normal lung compared to an obstructed and restricted lung. You can see that the obstructed lung right here appears larger than a normal lung, and the inspiratory capacity, inspiratory reserve volume, and expiratory volume decrease, while the residual volume, functional residual capacity, and total lung capacity increases. Like we discussed, this is because there is a decreased flow of air. And then right here in the restricted lung, you can see it appears smaller than the normal lung, with all the capacities and volumes decreasing. This is a result of inability to expand the lungs. In conclusion, lung capacity plays a large role in pulmonary function testing and allows for evaluation of suspected lung diseases. There are various types of pulmonary function tests, such as spirometry and plethysmography, that can help a physician diagnose lung and pulmonary diseases. Thank you so much for watching.